Hello everyone, I'm Dr. Abhishek Banerjee, Senior Lecturer in the Department of Oral Medicine and Radiology from BBDCODS, and I'm here to discuss this lecture on TMJ imaging techniques. First, the introduction. TMJ is a gyngymo-diarthrodial joint that is freely mobile with superior and inferior joint spaces separated by articular disc. Gyngymus means hinge joint and arthrodia means the joint that permits the gliding motion of the surfaces. Now the components of TMJ is a glenoidal fossa, articular eminence, mandibular condyle, articular disc and capsule, synovial fluid, discal ligaments, posterior attachments or retrodiscal tissues, ligament associated with TMJ, muscles of mastication, the arterial supply, venous drainage and sensory innervation of TMJ. This is the diagram showing the lateral view of temporomandibular joint. Now the diagnostic imaging of TMJ. The type of imaging technique depends upon the clinical problems associated. So either the imaging is done for the hard tissue or the soft tissue. Certain protocols are to be followed. The amount of diagnostic information available from the particular imaging modality has to be kept in consideration, and the cost of examination and the radiation dose. The TMJ imaging is separate for osseous structures and soft tissue structures. For osseous structures, we do plain film radiography, panoramic radiography, CBCT and CT. And for soft tissue structures, arthrography, MRI and USG. I will be mainly covering the topic of plain film radiography. Again, imaging of osseous structures. In this plain film radiography, we have transcranial projections, transpharyngeal projection, transorbital projection and submental vertex projection. Starting with transcranial view. It is a view that aids in visualizing the sagittal view of the lateral aspect of the condyle and temporal component. It is taken in both open as well as closed mouth positions. The TMJ indications are TMJ pain dysfunction syndrome, internal derangement and range of movement of the joint. And area of interest are lateral aspect of the glenoidal fossa, articular eminence, joint space and the condylar head. The film position. It is kept flat against the patient's ear, centered over the TMJ joint of interest and against the facial skin parallel to the sagittal plane. And position of the patient is head adjusted, so sagittal plane is vertical and ala tragus line is parallel to the floor of the floor. Central ray is directed at an angle of 25 degree from the opposite side through the cranium and above the petrous ridge of temporal bone. The horizontal angulation can be individually corrected for the condyle long axis, or the average of 20 degree anterior angle may be used. In closed mouth techniques, we see the size of the joint space, position of the head of the condyle, shape and condition of the glenoid fossa and articular eminence. And in open view, we see the range and type of movement, and then comparison of the both sides is made. Disadvantages is superimposition of ipsilateral petrous ridge over the condylar neck. In this, we can see the degree of translatory movement between the closed mouth and open mouth technique. Then transpharyngeal view, also known as the Parma projection or the McQueen-Dell technique. This technique provides a sagittal view of the medial pole of the condyle. It is taken only in open mouth position. Indications are TMJ pain dysfunction syndrome, osteoarthritis, rheumatoid arthritis, condylar head cyst for seeing the cyst or tumor, and in cases of fracture. Area of interest is lateral view of the condylar head and neck and articular surface. Film is placed, the patient holds the cassette against the patient's ear centered over the TM joint of interest against the facial skin parallel to the sagittal plane, half inch anterior to the external auditory meatus. The central ray is directed from the opposite side cranially at an angle of -5 to -10 degrees beneath the zygomatic arch through the sigmoid notch posteriorly across pharynx of the condyle, and then comparison of both side condyle is made. In this we can see the condylar head clearly. Then transorbital projection. It is taken in open or protruded position and depicts the entire medial lateral aspect of condyle in frontal plane. Indications is in cases of trauma and fracture cases. An area of interest is anterior view of TMJ, medial displacement of fractured condyle and fracture of the neck of the condyle. Film position is behind the patient's head at an angle of 45 degree to the sagittal plane. Position of the patient is sagittal plane is vertical and canthomeatal line should be plus 10 degrees to the horizontal with head tipped downwards. The central ray, the tube head front of the face and directed at a joint of interest at the angle of plus 20 degrees to strike the cassette at right angles. Point of entry is from two positions. First is from the pupil of the same eye or the medial canthus of the same eye. And the patient is asked to look forward with straight head ahead. Disadvantages is if the patient cannot wide open his mouth, areas of joint articulating surfaces will be obscured because of superimposition. In this, the condyle is seen below the articular eminence clearly. Then the fourth is submental vortex projection. A submental vortex projection provides a view of skull base and condyle in a horizontal plane. It is often used to determine the angulations of the long axis of the condylar head, so for corrected tomography. Indications is evaluating the facial symmetries and condylar displacement. These are my references.